I'd like to say hello and welcome you all to our webinar today. We are recording this webinar for future publication. We're pleased to have Dr. Ken Warrington give us an overview of vasculitis. You'll learn about the symptoms, how it's diagnosed, treatment, and management strategies. For many of you, this is your first webinar, so I'd like to briefly go over how these webinars work. After I introduce Dr. Warrington, he will present his slides, and then we'll do a question and answer session with him. Many of these questions were submitted in advance by our patients, but you can also submit your questions during this presentation by writing them in the question field that you see on your screen. Our moderators will be reviewing the questions, and we'll do our best to ask as many of them as possible. After the webinar, each of you will get a follow-up email, and a PDF of today's slideshow will be attached to it. And finally, this webinar is being recorded, and it'll be edited and put up on the Vasculitis Foundation website in the near future. So let me begin by introducing myself a little bit now. I'm Kathy Olevsky, and I'm honored to be the new 2020 educational webinar host. I'm bringing the patient perspective to the webinars this year. I was diagnosed with ANCA vasculitis back in 2008. I'm pretty sure my story will sound familiar to many of you. I went to 13 specialists before some lab work indicated that I was in kidney failure. My nephrologist ordered an ANCA test because he had just been to a lecture by Dr. Ronald Falk about vasculitis. And the next step was a kidney biopsy that confirmed the diagnosis of ANCA vasculitis. So later, under Dr. Falk's treatment, I had my kidney function restored to a pretty acceptable level through plasmapheresis, steroids, several drugs, including Cytoxan, Imuran, and rituximab. And I've been in remission off treatment for 6 years. So in my professional life, I own several martial arts schools, which my husband and my son and I operate together. I'm an 8th degree black belt in karate, and I've been teaching martial arts for 40 years, so that might give you a hint about my age a little bit. I actually write a monthly column for our industry magazine. I'm a speaker at conventions on the topics of teaching martial arts, women's empowerment, and running small businesses. I've been lucky enough in my remission time to travel as far as Australia and New Zealand as a professional speaker. And now I'd like to introduce, as we get started on our webinar, I'd like to introduce Dr. Kenneth Warrington. Dr. Warrington is a consultant and serves as chair in the Division of Rheumatology, Department of Internal Medicine at the Mayo Clinic in Rochester, Minnesota, with a joint appointment in the Gonda Vascular Center. Dr. Warrington is also the director of the vasculitis subspecialty group. He joined the staff of the Mayo Clinic in 2006 and holds the academic rank of Professor of Medicine, Mayo Clinic College of Medicine and Science. He's recognized with the distinction of the John F. Finn Minnesota Arthritis Foundation professorship also. Dr. Warrington earned his medical degree at the University of Malta and subsequently completed residency in internal medicine and his rheumatology fellowship in the clinician investigator program at the Mayo Clinic in Rochester. His research and practice interests are in the field of vasculitis, particularly large vessel vasculitis. He conducts clinical and translational research and has published extensively on these diseases. And so now I'd like to turn over the webinar to Dr. Warrington.
Thank you, Kathy. I appreciate the very kind introduction. I'd like to welcome everybody to the webinar, and just switching to my slide set here. So the purpose of this discussion is to really go over some common questions related to vasculitis, starting with some of the basics in terms of what is vasculitis, why do people get vasculitis, and so forth. And we'll go through these common questions together. So first of all, as you know, vasculitis is a condition in which there is inflammation of blood vessels. And starting with really what is inflammation, because I think we talk a lot about this, but sometimes it's difficult, I think, for patients with vasculitis to understand what inflammation is and how is it affecting their blood vessels. Inflammation is a process that the body uses to protect us from injury and to promote healing when there is injury or infection. But when inflammation affects a finger, I think it's easy for us to see it. Inflammation causes four main symptoms or findings, and those are pain, there is swelling, there is redness, and often warmth of the area. So as you can see here, if somebody sticks their finger or has an infection, I think it's easy for us to be able to visualize, to see that inflammatory process, but it is harder in blood vessels. And so when we are dealing with inflammation in blood vessels, similar processes happen, but of course they are happening deeper inside the body. Now, central to the process of inflammation is these white blood cells that you are seeing here that are, in this case, leaving blood vessels and going to the area where there is injury or infection. And these white blood cells are meant to help, one, to clean up any dying cells or any injured cells, but then also to promote the healing process and of course to restore normal body function. So in vasculitis, as I said, there is inflammation of blood vessels. So what happens when a blood vessel is inflamed? So in the finger, we can see it in a blood vessel. It can be a little bit more challenging. As you know, blood vessels are a tube. And if we were to cut this tube in cross section, and now looking kind of on end, we see that there is a wall to this blood vessel, and inside the blood vessel there is what we call the lumen, and that's the area where blood is going to flow through. We are seeing here a magnified view of red blood cells flowing through the blood vessel. Of course, the purpose of blood vessels is to carry blood. Blood is important because blood carries oxygen and nutrients to the organs that those blood vessels are supplying. Now, in the case of vasculitis, white blood cells find themselves in the wall of the blood vessel, and they are there inappropriately, right? So the inflammation, the process of these white blood cells invading the vessel wall is inappropriate. We'll talk about some reasons why that may happen, but really the actual cause is often unknown. But for unknown reasons, these white blood cells are then invading the wall of the blood vessel. Since the blood vessel is a tube, when there is inflammation, so we said that when there's inflammation, there's swelling. You are seeing here the swelling or thickening of the wall of the blood vessel. When there is that thickening, then you can see that the consequence of that is that the lumen, the inner part of the blood vessel where blood is meant to flow through, is now smaller, is compromised. And in the medical terminology, we call this stenosis, meaning narrowing. And sometimes there can also be complete occlusion or complete blockage. Well, this, of course, is going to cause problems with not enough blood getting to where it should go. In some blood vessels, like very small blood vessels, like this capillary, for example, so capillaries are the very smallest blood vessels, which are microscopic. There are capillaries in every organ in the body, and capillaries are so small and fragile that when these white blood cells invade the wall of the capillary, there may actually be breakage of the wall or leakage, and then blood is leaking out. And so again, this is damage to the blood vessel. But the bottom line is that in vasculitis, this inflammation, this invasion of white blood cells in the wall of the blood vessel is going to cause blood vessel damage. And when your blood vessel is damaged, then it cannot do its job being one of carrying blood to organs, to various parts of the body. And if blood cannot reach those parts of the body, then of course there's going to be damage. There may be organ failure, and the consequences of that we will talk about. So in vasculitis, again, there is inflammation of blood vessels. The blood vessels may become narrowed, like I said, stenosis, blockage or occlusion, or the blood vessels may leak. This is going to result in lack of blood flow, and the lack of blood flow is what then leads to damage to internal organs. So for example, just as we heard with Kathy, damage may be to the kidneys, causing kidney failure. Damage could be to other organs like the lungs, the skin, the nerves, and so forth. So vasculitis is not one disease. As you know, it's a group of conditions, and there are a number of specific conditions or diagnoses that fall under this umbrella term. They all have blood vessel inflammation that makes them, that kind of binds them in commonality. They are considered autoimmune diseases. Autoimmune meaning the immune system is turning on one's self. Like I said, the immune system should normally protect us from trauma or from infection, but in this case, the immune system is turning against its own body, and the immune system is attacking blood vessels. The vasculitis conditions we treat with immune suppressants, that is, medications that dampen the immune system or suppress the immune system because we want to stop the immune system attacking blood vessels. And rheumatologists take care of people with vasculitis because we are considered experts in the treatment of autoimmune conditions. We have expertise in the use of these immune suppressant medications. But of course, as you all know, and as we'll talk some more, it really takes a team of specialists to take care of people with vasculitis, depending on the organs that are affected by the condition. So some additional common questions that my patients come up with is it becomes confusing when we talk about what are the specific diseases, right? So one physician may say the patient has vasculitis, but some folks may have Wegener's disease, and then the kidney doctor says you have granulomatosis with polyangiitis or GPA. So the terminology can be a little bit overwhelming, and we'll go through some of these specific conditions and names in vasculitis. So like I said, again, this is just showing kind of a picture that vasculitis is a general umbrella term, and there's all these individual diseases, giant cell arteritis, microscopic polyangiitis, GPA, eGPA. They are all different forms of vasculitis, and so they fall under this umbrella term we call vasculitis. So the issue is then how do we sort through all of this? How do we put patients into the specific category of these particular diseases? So when we first see a patient who we think may have vasculitis or who we know has a diagnosis of vasculitis, as physicians, we think about what size of blood vessel is predominantly affected in that particular individual. And we sort blood vessels out into three main categories, going from large to medium to small. So the biggest blood vessel in the body is the aorta that we see here. This is the big kind of channel or blood vessel coming out of the heart. And the aorta has branches that go off to feed the head and neck and off to the arms and then down to the rest of the body. When we see somebody that has vasculitis involving these large blood vessels, the aorta, the arteries to the head and to the arms, then there are two main conditions, those being giant cell arteritis, generally in people over the age of 50, and in younger women, often below the age of 40, Takayasu arteritis is the condition that would also fall under the category of large vessel vasculitis. In adults, when we look at a condition that affects the medium-sized arteries, so these are now arteries that are a little bit smaller than the aorta. They are branches that are now going into the kidney, for example, or to other organs. And this condition here is called polyarteritis nodosa. So in this category, in adults, there is only one condition that falls in this group. And then there are many more conditions that fall under the small vessel vasculitis category. This is just a blown up picture of a kidney. So this would be a small piece of a kidney taken from here, which some of you may have had a kidney biopsy, and we are looking for those very, very tiny microscopic blood vessels now that can be involved in ANCA-associated vasculitis. So for example, in GPA, in MPA, and eGPA, those three conditions fall under the category of ANCA-associated vasculitis, and these diseases affect the smallest blood vessels in the body, often capillaries and other small arteries. There are other conditions, including IgA vasculitis, Cryoglobulonemic vasculitis, those fall under this category of small vessel vasculitis. So this helps us provide a framework when we're seeing a patient with vasculitis as a physician. We try to understand, is the condition affecting the biggest blood vessels in the body, the smallest, or is it somewhere in between? And this helps us start to understand which category of vasculitis we're dealing with. Now, there are some patients where, despite doing all testing, we're not able to get down to this level of kind of specificity in terms of a specific diagnosis. And in some patients, we do use the more general term of vasculitis because sometimes with testing, we're not able to really figure out exactly which category. But of course, the important thing is that we do arrive at a diagnosis of vasculitis and that we are able to start treatment, maybe without being able to get into the fine-tuned specific naming of a condition. Then there are some conditions like Behçet's disease, where Behçet's can affect various forms of blood vessels. So it could affect small blood vessels, medium blood vessels, or large blood vessels, and we call that variable vessel vasculitis. Then there are situations where the vasculitis can affect only one organ system in the body. For example, this person has vasculitis that is only in the skin. This person, unfortunately, has vasculitis that is affecting the brain, also called CNS or central nervous system vasculitis. Again, in most people with vasculitis, as many of you know, the condition affects multiple organ systems. There may be inflammation in the lungs, the skin, the kidney, the nerves, kind of all at the same time. So in most people with vasculitis, multiple organs are affected, but there are individuals where the vasculitis affects only one organ. And again, these are examples I'm showing here where in this case it affects only the skin, and in this case it affects only the brain. So this is again kind of how we try to categorize, or how we try to divide up the various forms of vasculitis. But moving on, I'd like to talk a little bit about some other aspects in terms of who gets vasculitis, why did I get vasculitis, and those are difficult questions to answer because vasculitis really can affect anybody. So it can affect both children of any age as well as adults, really, again, of any age, young adults, all the way through older adults. Both men and women are affected. All races are affected. Vasculitis occurs worldwide, but we do have some clues because certain types of vasculitis may affect some individuals or group of individuals more than others. For example, when we think about giant cell arteritis, that tends to be more common in people of Northern European descent. So generally white races would be more affected with giant cell arteritis. On the other hand, something like Takayasu arteritis, even though again it is seen worldwide, it is somewhat more common in Asian countries or in individuals of Asian descent. So again, this is not a clear-cut rule, but we do see that some certain forms of vasculitis are somewhat more common in certain parts of the world. Oftentimes, we don't know of a specific cause of vasculitis. Oftentimes, we believe that there is a combination of several factors that lead to the development of vasculitis. One of those is genetics. And when we talk about genetics, it is not, unfortunately, a simple single gene condition. The genetics is complex. We know that there are multiple genes involved. So basically, the person who develops vasculitis oftentimes has to have a specific set of genes that kind of come together in the right combination in the right individual. But then having the right combination of genes is probably not enough. There may be a trigger in the environment. There have been a lot of studies looking at potential infections that may trigger vasculitis. So again, it's a combination of factors, likely genetic, likely something in the environment that triggers these diseases. But again, a lot of the exact mechanisms have not yet been fully figured out. There are some situations where medications can trigger vasculitis. For example, there is an antibiotic called minocycline that sometimes can trigger a condition that looks like polyarteritis nodosa. There are some other conditions, there are some other medications, for example, the TNF inhibitors that we use for rheumatoid arthritis, and many others. Antibiotics can trigger vasculitis in the skin and so forth. And then smoking appears to be a risk factor for several forms of vasculitis. We and others have specifically been interested in smoking as a trigger for giant cell arteritis, and in one of our studies we saw that it increases the risk by about 20% or so. So again, things in the environment, infections, medications, smoking, all could contribute to vasculitis. There are some infections that we know directly can trigger vasculitis, such as chronic hepatitis and HIV, but those are a very small subset of causes of vasculitis. When patients first come to us with vasculitis, oftentimes one of the first questions is, and Kathy just mentioned this in her introduction also, is why did it take so long to diagnose this disease? Why did I see so many doctors and specialists before they were able to diagnose me with this? This is often a source of frustration, understandably, for patients. But really, it is because vasculitis is so rare, right? And as a primary care provider, maybe as an internal medicine physician, they are looking for the needle in the haystack. And this is what leads to the delay in the diagnosis, is because doctors are trained to think about common things first, because common things are common. And then, of course, they go through the more common possibilities for diagnoses. And eventually then somebody starts to think about perhaps this is an uncommon condition, which leads to testing for vasculitis. But again, because they are rare, unfortunately, there is often a delay in getting to a diagnosis. And I think there's a lot more awareness, of course, both among patients and among physicians, and that awareness is increasing, and that will be helpful in picking up these conditions more efficiently. So just mentioning, how common is vasculitis? And briefly, I just wanted to mention giant cell arteritis, because this is the most common form of systemic vasculitis, meaning the form of vasculitis that can affect various different organs in the body, different body parts. And so giant cell arteritis affects about 1 in 5,000 people who are over the age of 50 each year. It's estimated that women have about a 1% lifetime risk of developing giant cell arteritis. So again, not the most frequent condition, but not extremely rare either. And giant cell arteritis, as you may know, affects the blood vessels that go to the head, which is why patients often come in with head symptoms such as headache, and it can also affect the blood vessels that are going to the arms as well as the aorta. Again, that's that main artery that's coming out of the heart. But other forms of vasculitis are less common. So for example, when we discuss Takayasu arteritis, that only affects a couple of people per million each year. So then we go to the very rare forms. When we think about polyarteritis nodosa, again, it really is a few per million per year. And then when we think about the ANCA-associated vasculitis, again, we're on the order of maybe 10 to 20 per million per year. So these are rare conditions, and therefore in a primary care setting or even an internal medicine office, a physician may only have 1 or 2 patients with these conditions just because of the rare nature of the disease. And then vasculitis can be puzzling, because vasculitis can start up in any organ. It can therefore cause a lot of variable symptoms. Sometimes the symptoms are kind of vague to begin with. And so they can be difficult to recognize. It can be difficult to recognize both for the patient and also from the physician perspective. So for example, if we think about ANCA vasculitis, oftentimes some of the initial symptoms are just not feeling well. So there may be excessive fatigue, not feeling well, maybe a low-grade fever, but then GPA and MPA can cause inflammation in the eyes, which will cause redness, pain. There is often inflammation in the sinuses, so patients will have recurrent sinus inflammation. They may have been on a number of antibiotics to try to treat some sinus infection, which really doesn't often help very much. There may be symptoms related to hearing. There may be symptoms oftentimes of muscle aching, joint pain, joint inflammation, meaning joint swelling and joint stiffness. There may be symptoms related to lung inflammation, such as cough, such as coughing up blood or pain in the chest. There may be blood in the urine. There may be symptoms of nerve damage, and that often starts up as numbness or tingling in the arms or the legs. There may be symptoms in the belly where there are belly pains or perhaps bleeding with bowel movements. So the idea here is to really help you all understand that the symptoms can be many, many different ones. And sometimes if the predominant symptom, for example, starts with eye inflammation, the patient may seek care at an eye doctor. This patient may be going to an ENT doctor first. This patient may be going to a rheumatologist. This person may start up with a lung specialist. This person may start up with a kidney specialist, and so on and so forth. So you can see why there is why so many doctors are involved, because you have all these different body areas that are affected, and why sometimes it's difficult for a physician to put all the pieces of the puzzle together and really say, you know, putting this and this and this and this all together maybe really we're dealing with something like GPA and MPA. So here are some pictures to help explain. This is a patient with inflammation in the eyes, a condition called scleritis, which causes a lot of redness of the white of the eye, inflammation and pain. This is a scan of a patient with vasculitis who has these lung spots or nodules and who has a lot of cough and breathing symptoms. This is vasculitis in the skin, which causes this rash that we call purpura, these reddish purplish blotches on the skin. This is somebody who has a wrist drop, meaning they're not able to elevate and use their hand because there is nerve damage from vasculitis. So again, the point here is that vasculitis can affect many different parts of the body, sometimes at the same time, and that can make it difficult for physicians to really pinpoint the diagnosis. When we talk about large vessel vasculitis, some of you may have giant cell arteritis or Takayasu arteritis. Again, there may be weeks and months of symptoms such as fatigue or low-grade fever. In giant cell and in Takayasu, there may be loss of blood supply to the eyes, which can lead to loss of vision or even blindness. Again, joint inflammation and muscle pain is common. There may be neurologic symptoms such as dizziness or headache. If the blood vessel to the arms is affected, then there may be pain in the arm. When one is using the arms, there may be belly pain. So again, the idea is that we are referring to symptoms that affect different body parts, may be difficult for physicians to recognize, and lead to that delay in the diagnosis that we mentioned. A team of doctors is needed, as we said, because of these various components of the vasculitis. So if there is eye inflammation, we enlist the help. We ask for help from an eye doctor, the ENT specialist, the kidney doctors, the lung specialist, a neurologist who deals with brain and nerve symptoms. A skin doctor may be asked to help if there is a skin rash. Sometimes we ask our help from vascular medicine or surgery colleagues who really deal with blood vessels, especially when there is the need for a procedure such as an angioplasty or a surgical bypass. So again, it is a team of doctors that's very important for patients with vasculitis. It's important that these teams of doctors talk to each other and that they correspond, that they are aware of what the other person is doing so that the treatment can be organized so that everybody's on the same page and we can provide the best care to the patient. So, some other common questions that often come up is, what do my blood tests mean? Of course, when you go to the doctor, one of the first things we do after getting a history and examining the patient, we send off for a bunch of blood tests. And in people with vasculitis, as you may know, we order a lot of tests, and we'll go through some of those more common ones. So first things first, we often start with looking for inflammation because, as we mentioned, in vasculitis, there is inflammation in blood vessels, and that inflammation spills over into the bloodstream so we can measure it. And the two most common tests that we have for inflammation are the SED rate. The full term is the erythrocyte, meaning red blood cell sedimentation rate. And basically what we're looking at is how fast the red blood cells fall in a column of blood. So the blood is put into a glass tube, basically, and then they look at how fast these red blood cells kind of precipitate or fall in the tube. It's not a very accurate test. The CRP, on the other hand, tends to be more accurate. This is a direct measure of inflammation. It's processed by a machine. The one thing to watch for the CRP is that some labs have different normal ranges. So in some labs, it's measured in a unit called milligrams per deciliter, so that the normal is somewhere less than 1. But in some labs, at Mayo Clinic, for example, it's measured in milligrams per liter, and our normal is up to 8. So it's very important to know that if you're communicating these results to your physician, if you are monitoring them or charting these numbers, to make sure that the lab is consistent, or at least that you are aware that there may be some variability from lab to lab in terms of the units that are being done in that lab testing. So we use these markers. They're not perfect, of course, as you know. These markers are not specific, meaning these markers can go up with other illnesses, main thing being infection. So if somebody has, for example, influenza, these markers may go up, and we have to then tease out, are these markers elevated because of vasculitis or because there may be something else going on, like an infection. And then for ANCA vasculitis, the most helpful test is the ANCA test. And ANCA stands for anti-neutrophil. Neutrophils are white blood cells. So these are antibodies. They are proteins that the body makes in people with vasculitis. They shouldn't be there normally. But in people with vasculitis, the body makes these antibodies that stick to white blood cells, to neutrophils. And we can test these in the blood. They are helpful for reaching a diagnosis. So in people with GPA or with MPA or with EGPA, we often see a positive C-ANCA or positive P-ANCA. And then, not to complicate matters too much, but the lab will often do a combination of testing, and C-ANCA goes along with a test called PR3, and P-ANCA goes along with a test called MPO. So you may see your physicians checking both of these. Again, they are helpful for the diagnosis, and we often check them periodically during the disease process to see how those tests are doing over time. The interpretation can be complex, and I don't want to spend too much time on that here today, but I would encourage you to kind of discuss this with your physician in terms of really understanding what these numbers mean. But they are a helpful test, like I said, primarily for diagnosing the disease. But then we send you off for a lot of tests because we have to check all major organ systems. We want to check the kidneys, we want to check the liver. We want to see if patients have been exposed to hepatitis or to tuberculosis. We do that testing routinely because when we treat vasculitis, we are going to use these immune suppressants. And when we use immune suppressants, we want to make sure that patients are not carriers of TB or of hepatitis because we can cause problems if folks have been exposed to TB, and we want to know about that before we start the immune suppressants. And that is why we do this testing before, basically on every patient with vasculitis before we start treatment. And then we want to get pictures. So when we're concerned, is there vasculitis in the aorta? Is it in the chest? Is it in the belly? So we often will get either chest x-rays or CT scans to look, for example, at the lungs. So this person has a chest x-ray and we see all this fluffy white stuff in the lungs. That tells us that there's something wrong in the lungs, either inflammation or hemorrhage, and that the lungs are affected by vasculitis. As you may have experienced, the one of the most definitive tests for vasculitis is a tissue biopsy. So that's when we put in a needle, we take a very small sample of oftentimes just a few millimeters thick, but we take a small sample from an organ that is affected. That may be the skin, that may be the lung, that may be a kidney, that may be a blood vessel, such as in people with giant cell arteritis. We take a piece of artery from the head. Then this biopsy, this tissue, can be examined in the microscope. And in the microscope, again, we're looking for that inflammation in the blood vessel that we discussed earlier. And when we see that inflammation, that pretty much gives us a kind of the gold standard, or really gives us in black and white, this is a clear answer that this is indeed vasculitis that we are dealing with. Here's an example of what we might see in a microscope when we're looking at a lung biopsy. And this is comparing a normal lung tissue. So the lung has this very, very thin network. It sort of almost looks like a sponge. And there are wide open spaces in the lung to allow oxygen to come through. And that's how the lungs work. When there's vasculitis and inflammation, you can see now the lungs are full of these white blood cells and sometimes red blood cells. But when the lungs are congested like this, there's not enough space for oxygen to come across. And that is why then patients may be experiencing shortness of breath or maybe coughing blood. This is because of the damage that we are seeing in the vasculitis. When we are dealing with large vessel vasculitis like giant cell arteritis or Takayasu, we often will see that the markers of inflammation are high. We then often go on to doing a biopsy from an artery at the side of the head here, called a temporal artery biopsy. We may be doing a CAT scan. This is an example of a CT scan that helps us see whether there is inflammation in the blood vessels. Here's the aorta, the main artery in the chest, and this is what helps us figure out whether somebody has large vessel vasculitis like GCA or Takayasu. We may do CT scans or MRI scans. CT scan is basically where the patient goes through this donut. The donut takes oftentimes thousands of pictures in a very quick way. You often will see that there is a dye injected. The dye helps us to really kind of bring out those blood vessels on the scan so we can see what's going on the inside. The MRI scan is similar, but different in that the machine is more of a tube. And so this can raise some concern, especially patients who have difficulty being in a closed environment. But both CT scan and MRI are very powerful tools that allow us to see inside the body, that allow us to see blood vessels, and they can be a very powerful tool to understand where the vasculitis is affecting and really understanding, does the patient have vasculitis and which organ systems are being affected by the vasculitis. So in conditions like Takayasu or giant cell, for example, we're looking at thickening. This is just an example showing this gray rim around the blood vessel. So this is the white area is where the blood is flowing through. That's the dye in the blood vessel. And this gray rim is showing the inflammation, which is very different from what looks very normal here. So normally arteries have a very, very thin wall where you can barely see it on the scan. But when it's thick like this, that indicates that there is that inflammation. This is very similar to the cartoon I showed you earlier. And this is what we're looking for to make a diagnosis of vasculitis. Sometimes with an MRI scan, we can see this bright signal kind of lighting up in the wall of the aorta that again tells us there is inflammation. We also use these scans to look for narrowing in the blood vessels. So for example, this is somebody with Takayasu, where here we have developed narrowing in the artery, and that is something, of course, that is a consequence of vasculitis. Sometimes we use a more complex scan like a PET scan. A PET scan is performed by injecting a small amount of sugar. The sugar is radioactive, and the sugar goes to areas where there is inflammation. So in this patient, we are seeing kind of the aorta lighting up with this greenish yellow red signal, which means that the sugar is going to the aorta, and that means the aorta is inflamed. It tells us that is vasculitis. It tells us that this is where the inflammation is, and it helps us make a diagnosis of large vessel vasculitis, oftentimes either giant cell or Takayasu. The PET scan is not as helpful in people with ANCA-vasculitis because in ANCA-vasculitis, the blood vessels are so tiny, it's the capillaries that are affected, and they are too tiny to actually be seen on a PET scan. Sometimes we need to do an angiogram or a biopsy. So for example, here we're looking at the blood vessels inside a kidney. An angiogram is where a physician puts a small catheter, sometimes in the groin area, and then they inject a dye, and the dye kind of gives us a picture, an outline of the blood vessels. And here we are seeing some very small pockets of aneurysms, which is something we would watch, something that we would see in vasculitis. Some other questions, moving on to questions of how is vasculitis treated, right? How do we stop this immune system from attacking the blood vessels? Is vasculitis curable? Here, unfortunately, we're not there yet. There's a lot of research going on in vasculitis. There's certainly a lot of hope, but up until now, we're generally not able to completely cure the vasculitis, but it certainly is treatable, and we have a range of medications that we use to treat the disease and to keep it in remission. So the goals of treatment are really to stop the immune system from attacking the blood vessels. We want to reduce the inflammation. We want to kind of tell the immune system to quiet down and to stop attacking the blood vessels. We have, again, a wide range of medications, and those go from medications that have various degrees of strength, how strong the medication is, and of course, the more severe the disease, that is going to depend on which medications we choose, depending on the type of the vasculitis. We want to save the patient's life. I know there are some questions later, but one of the concerns, of course, is that certain conditions such as ANCA vasculitis, without treatment, there is a possibility of people losing their life if they are not treated. And so the first goal is we want to make sure that the patient's life is protected. We want to prevent damage to tissues. We want to prevent that kidney damage. We want to prevent that lung damage. And we want to improve the quality of life. We want people to get back to doing things they enjoy doing, and really bringing the quality of life back to where it was before that individual developed vasculitis. But the treatment of vasculitis is complicated, right? We have to consider the risks of the vasculitis, because vasculitis can damage organs. It can take away people's quality of life. If a person is spending time in the hospital, if a person is spending time in pain, if a person is spending time in the doctor's office, that's impacting their quality of life. We want to give treatment to help this. But then we also have to be understanding that treatment carries its own risks, right? Treatment can cause an increased risk for infections. Prednisone has a lot of side effects. Depending on the medications, all of them have side effects. And so it's a delicate balancing act with balancing the risks of the vasculitis, balancing the risks of the treatment. And what I tell patients is that at every doctor's visit, that is really what the visit is about. The doctor is assessing, how is the vasculitis doing? Are there any risks from the treatment? Are there any complications from treatment? And kind of thinking about at every visit, do we need more treatment or less treatment, or do we stay the course? So again, when the vasculitis is newly diagnosed, we call that phase as being active, right? The patient is newly diagnosed, and the first thing we want to do is we want to put out the fire. We want to stop that inflammation. We want to induce remission, meaning we want to quiet down that inflammation. And then once we've achieved remission, meaning once we've brought that inflammation down, we want to maintain remission. So then we talk about remission maintenance, meaning we want to stop the disease from coming back. But sometimes we do encounter relapses or flares. The disease does recur. And so then we have to kind of start over and re-induce remission. So these are kind of the phases of vasculitis. So I know perhaps many individuals in the audience may have ANCA vasculitis. So you know that in ANCA vasculitis, we use prednisone quite a bit to treat, to induce remission, often in combination with medications such as Cytoxan or rituximab. To maintain remission, we often use medications like methotrexate or azathioprine or mycophenolate, or now we are using more rituximab to keep the patient in remission. If there are relapses, we often have to start prednisone back on, and then again, depending on the type of relapse, we will use a combination or one of the medications listed here to kind of restart the cycle. Similarly, in giant cell arteritis, we give prednisone. In the last 2 years or so, there has been more use of a newer medication called tocilizumab, which helps us to induce remission. We maintain remission with prednisone oftentimes and may use tocilizumab. And then, of course, again, if there are relapses, we treat with the same medications and restart that cycle. There are some common principles regarding treatment. We want to make sure everybody is following a healthy diet, staying physically active as much as possible. Again, with the medications, there is a higher risk of infection. And so we want to follow some common sense strategies to try to prevent from getting sick. And therefore, we want to try to avoid being around people who are sick. We want to be very careful with hand hygiene, either careful hand washing, using things like hand sanitizer and so forth. If there are concerns of an infection, then to seek medical attention right away. It's important to try to prevent things that are preventable. So as you know, there are immunizations against influenza, against pneumonia, against shingles. And now for shingles, there is a newer vaccine called the Shingrix, which is a vaccine that can also be used in people who are on immune suppressants. When individuals are being treated for vasculitis, we typically do not allow live vaccines to be administered. There are not many of these. There was an older shingles vaccine, which is often no longer used, but if it is a live vaccine, then we do not want our patients to receive that because their immune system is suppressed. We will often prescribe an antibiotic to prevent a rare form of pneumonia called pneumocystis. This is a form of fungal pneumonia. It's a fungus that can affect the lungs and cause a serious form of pneumonia. And so many of you may have heard or have been on a low dose of an antibiotic to prevent this form of pneumonia. As you know from glucocorticoids, from prednisone, there is a risk of bone thinning, and therefore we use medications to prevent bone loss. So in vasculitis, once we make a diagnosis, we want to treat the disease, we want to prevent flares. And the main concern is that every time a patient has a flare, there is concern that that flare may be causing damage to the organs, whether that be the kidney, the lung, the skin, the nerve, and so forth. And so what can be done to reduce damage from vasculitis? The main important things are early diagnosis. So any patient who there is concern for vasculitis, we want to try to get to a diagnosis as quickly as possible. We want to start treatment to shut off that fire, to turn off that inflammation and induce remission. Of course, follow-up with providers is important, whether that's a rheumatologist or sometimes a team of doctors, lung doctor, kidney doctor, etc., because we want to try to minimize relapses or at least catch them early before there is damage to internal organs. We want to also try to reduce damage that's related to medications, right? So as you know, prednisone can cause a number of side effects. Other medications, all medications have side effects, and we want to balance that carefully with your provider. And that's one reason we do this regular monitoring with lab tests, is to monitor not just the disease, but then to monitor the medications and to monitor for side effects. I am very pleased that you are all participating in this webinar, because I think patient education is really important, because you are the most important advocates for your health. And I personally really enjoy interacting with patients who are knowledgeable about their disease, who can partner with a provider to form a team, and the patient is a critical part of that team to have a successful treatment relationship, again, with good communication, asking questions, interacting with your providers is really essential. Kaylin did a beautiful job of outlining and encouraging participation in research studies, and as you know, there are a broad range of research studies that are going on in vasculitis. And I will wrap up here, because I know we have a lot of really excellent questions that I would be very happy to start to address. And again, thank you all for participating, and thank you all for your attention over the past hour.
Well, thank you, Dr. Warrington. We really appreciate that in-depth information. We are going to have a question and answer session now with Dr. Warrington. We have some questions that were submitted in advance, and some of you have been submitting questions during this webinar. I do just want to say we have, it looks like about 175 of you out there listening today. That's so exciting, and we know you all have questions, and we're not going to probably get to all of them today. So we are already formulating a second webinar that will handle more of these questions and get answers from Dr. Warrington, and we'll put that information up about that later. Since this webinar is so popular, we are going to make sure we get most of the questions that you've sent to us answered as quickly as possible. And as a reminder, this is being recorded, so it will be put up on the Vasculitis Foundation website in the near future. So let me start with some patient questions that have come in, Dr. Warrington. The first one is it more important for me to learn everything about my form of vasculitis or about vasculitis in general? What are some of the differences in how vasculitis is treated from one form or another, or is treatment basically the same for all of them?
Yeah, great question. I think the short answer is both. So I think it's important to understand kind of the general concepts of vasculitis, just like we talked about today. But then, of course, I think if an individual has a specific diagnosis, so if you've worked with your physician, provider, and have a specific diagnosis, for example, a diagnosis of GPA, then of course I would encourage you to learn or to read materials specifically developed for GPA, because as we said, different forms of vasculitis have a lot of differences from one to the other. There are differences in terms of the symptoms, differences in terms of the testing, and differences in terms of the treatment. So again, I think it's important to have a general understanding of vasculitis, but then to kind of get a more in-depth understanding of the specific condition is important.
Well, thanks. That makes a lot of sense. Another question is, I've heard that statin drugs to treat high cholesterol also lower inflammation. Are they effective for vasculitis?
Yes, very interesting topic. We and others, and many others, have looked into statins and their effects. No doubt, of course, they help with cholesterol lowering. They may help. There is some data that they may help with inflammation in atherosclerosis. That's kind of hardening of the arteries related to cholesterol. In terms of the effect of statins specifically on vasculitis, that really has not panned out in research. So we did a research study in people with giant cell arteritis to see whether statins had an effect on the disease process itself, and we did not see such an effect. So as of now, the short answer is no. There does not seem to be a specific effect of statin on vasculitis, but of course, if statin is required for treatment of cholesterol, then certainly that would be, just as in the general population.
Thank you. Another patient said, I've been on rituximab for 3 years now, and I'm afraid of relapsing if I come off of it. I relapsed twice before rituximab, and the second relapse cost me my kidneys. I haven't relapsed since being on rituximab. I have a big concern about having to go on prednisone again, and if I relapse, will I need to have prednisone, or could I go straight back to rituximab?
A complex question, and of course, I think the precise answer really lies in a discussion between the patient and the provider, because there are so many factors that are embedded in that question. Few general comments. One, rituximab is very effective at maintaining remission. In other words, it's very effective at preventing relapses. There are still some unknowns about the use of rituximab in terms of how long should rituximab be continued in somebody with ANCA vasculitis. So I think there is still ongoing research and opportunities for research to understand, is the optimal duration of rituximab 2 years, 3 years, 4 years, 5 years, etc. So until we have more research, it really is an individualized decision and discussion between the specific patient, depending on their specific type of vasculitis, depending on the type of relapse, in order to determine how long to be on rituximab. One of the issues that we see with rituximab over time is that some patients may develop a condition called hypogammaglobulinemia, which means that their antibody levels in the blood start to drop. And so that is something that we monitor in people with Rituxan periodically, is these immunoglobulins, because we don't want the immune system to be overly suppressed. So again, the provider has to weigh in all these factors in terms of deciding how long to continue the Rituxan. And the question was, does it have to be in combination always with prednisone? And the answer is no, it does not always have to be in combination with prednisone. It just depends on the severity or the type of the relapse. Of course, we do give a small amount of prednisone anyway with each rituximab infusion, but that's primarily to prevent reaction to the Rituxan. So a complex question with a complex answer.
Oh yes, a great answer though. I would like to say to the listeners that I was on my last infusions were rituximab 6 years ago, and I am on nothing now. So some people asked, you always have to stay on it. I'm not. So
Correct.
Another question that's very similar or related to that is, somebody says, do you ever see a day when steroids will be greatly reduced or even eliminated as a standard treatment?
Yeah, that is really a timely question, because of course, as physicians, we are always wanting to use as low an amount of prednisone as possible, because we are all very much aware of the side effects. So that is a very current kind of area of research. As some of you may know, not too long ago, a major trial called PEXIVAS was published, and this trial was looking at plasma exchange, but it also studied whether patients could be treated with less prednisone than we use traditionally. And it's interesting, that trial showed that we could get away with using less prednisone in people with ANCA vasculitis. There is another very exciting development. There is a medication called avacopan that is being tested in clinical trials, and it may be able to replace either partially or maybe even completely replace prednisone. So yes, I think that's one of the most exciting parts of the field of vasculitis right now, is trying to reduce the amount of prednisone, maybe someday even eliminate the use of prednisone for vasculitis. Of course, for a condition like giant cell arteritis, we've used prednisone for 70 years, and it's really only been in the last 2 years that we now have tocilizumab or Actemra that helps us to reduce the amount of prednisone that we use. So yes, a very, very exciting field of research.
I think that's great to know. I've been in a lot of these Facebook groups, and people talk about the steroids being one of their big concerns. I will tell you that another question that's come up commonly is, this patient says clearly, I'm afraid of having to be on methotrexate for my vasculitis. I've heard that it can cause cancer. Is this true?
Yeah, so as we mentioned, I think as a provider, we have to, and as a patient, we have to weigh the risks of the disease and the risks of the medication. The one good thing about methotrexate is we have many, many thousands or millions of patients on methotrexate for rheumatoid arthritis. So because rheumatoid arthritis is so much more common, it allows us to accumulate a large amount of data regarding the side effects of methotrexate. So we have a very, very good understanding of what the risks of methotrexate are. And to be honest, the risks of cancer from methotrexate is very, very small. There is a slight increase in risk of skin cancer with methotrexate, maybe about a 1% risk. In terms of other cancers, there is a very small concern regarding the possible development of lymphoma. But it is a very, very rare occurrence, probably less than 1 in 1,000. So in general, I would say the risks of vasculitis are higher than the risks from methotrexate. So in general, methotrexate is a very well-tolerated medication, and the likelihood of risk from methotrexate is extremely, extremely small.
Well, I hope that puts a lot of people's mind at ease. We did want to also ask you, what have been the biggest breakthroughs in vasculitis research in your career? Like, what do you think is the most promising down the road to treat it?
I think in just a general statement, I think it's really the arrival of these biologic medications that we are seeing used in almost all forms of vasculitis. And by biologic medications, I mean injectable or infusion type medications that are these antibodies that are replacing, for example, in ANCA vasculitis, we have seen Rituxan replace, for the most part, the older, more typical chemotherapy medicine like Cytoxan. We have seen Rituxan kind of replace that. Generally, a safer alternative. In giant cell arteritis, we have seen development of this biologic tocilizumab or Actemra, which is very promising. In Takayasu, there has been increasing use of TNF inhibitors, like, for example, Humira. So in many forms of vasculitis, really over the last 5 to 10 years, it's really the arrival of these biologic medicines. And I think we will continue to see more of these agents, because of course many of them are being studied in ongoing clinical trials. So it is a very exciting time. Of course, oftentimes these drugs are initially trialed in more common conditions like rheumatoid arthritis, and then we learn about the medicines, we learn how to use them, and then we test them in people with vasculitis. But I think there is a lot of hope.
Well, that's great to know also. I think we're going to ask one final question, and we've already said to the viewers that we're going to develop a second webinar with all of the questions and try and get all the answers. But this last one is, can you help explain the mortality rate with vasculitis? I've read it's 5 years, but isn't that only if the vasculitis is not diagnosed and not treated? What is the mortality rate for a patient who's being treated and managing the disease?
Yeah, that's an excellent question. Of course, we want, as providers, we want the mortality to really be no different. I was going to say zero, but you can, but of course that doesn't make sense, right? Because we're all prone to mortality at some point, and really it's a question of we want the mortality in patients with vasculitis to be no different than that in patients who don't have vasculitis, because of course we all know that we all have an end to our lifespan, but we want the lifespan of people with vasculitis to be no different than the general population. Now, in some forms of vasculitis, that is true. So, for example, in people with giant cell arteritis in general, their survival, meaning their lifespan, is about the same as in people who don't have giant cell arteritis. There are a few individuals with giant cell arteritis who may have a shortened lifespan, and that is related to the development of aortic aneurysm. But if we can screen for aneurysm, then we can intervene or fix that before it affects people's lifespan. Now, in ANCA vasculitis, it's different. So in ANCA vasculitis, up until maybe 30 years ago or so, we know that if without appropriate treatment, then 80–90% of patients with ANCA vasculitis may lose their life within the span of 2 years. That's in the era where there was no effective treatment, or if the vasculitis is not treated. So if the vasculitis is not treated with ANCA vasculitis, then there is a very, very high mortality. But in the current era, with the appropriate use of treatments, then the mortality is way, way lower. Now, it's very variable because it depends on the particular study. It depends on the severity of the vasculitis. And so different studies quote different numbers, but it is now, on the order of somewhere between 5 and 20%. And again, we only see that really in people who have the most severe forms of vasculitis, often in intensive care unit and so forth. So we have made a tremendous improvement on the survival of patients with all forms of vasculitis.
Well, that's comforting to know. I know that is one of the main topics or the main concern in many patients' minds, including my own. So it's great to hear that things are changing. At this time, we want to move towards the end of our webinar, and I want to say especially thank you to GlaxoSmithKline and Genentech for their support of our webinar series. They're helping the Vasculitis Foundation provide these valuable educational webinars, and they support our commitment to creating patient education. And then I also want to say that the go-to resource for patients with vasculitis is the Vasculitis Foundation website. It's a great educational and supportive resource to help patients better understand and manage this complex disease. You're not alone. You can find information on all the various forms of vasculitis, order disease brochures, use the Find a Doctor feature to locate medical professional or centers that treat vasculitis. In 2020, there will be a series of regional conferences throughout the country. Visit the website to learn when, where, and then these one-day conferences will be held. And also, please check out our video educational library under the Learn tab. Here, you can watch past webinars. You can actually watch this webinar when we put it up in the short future. And we have video presentations from some of our conferences and also the 2019 symposium. So there's a lot going on with the Vasculitis Foundation, and I'm going to recommend one thing you should do today. And here it is. The one thing you should do today is to get you plugged into everything that's happening with the Vasculitis Foundation. Subscribe to our monthly digital newsletter called the VFE News. Every month, it's delivered to you as an email, and you'll find out about upcoming webinars. I encourage you to go there after this webinar and subscribe today. Our next issue of the VFE News is coming out very soon. And one final thing today is that you'll get an email with a very short survey about your experience in today's webinar. The webinar series is a work in progress, so we want your feedback so we can continue to make them better. You'll be able to tell us what you did like and how can they be improved. Is there some topic you would like covered in a future webinar? Your responses and questions will really help us. So thanks in advance for your feedback. And I would really like to thank Dr. Warrington and Kaylin Young for their willingness to be part of our webinar today. I'd also like to thank all of our listeners. And lastly, I'd like to say, I'm on this journey with all of you. So join us again on the Road to Wellness webinar series.